Practically, it would be difficult to believe that this classroom is being occupied by mental health patients. This is because the room is peaceful, neat and organized, and yet most mental health victims are usually rowdy and uncontrollable. Mental health disorders are often characterized by abnormal social behavior and failure to recognize what is real. The common symptoms include false beliefs, unclear or confused thinking, auditory hallucinations, reduced social engagement, emotional expression, and inactivity. The case here is, however, different, as these patients are under proper medication and care. It's because of this that they are also being empowered in how to advocate for their rights, both at the district and national level.
People with the mental, neurological and substance disorders always suffer from stigmatization and discrimination and isolation, and naturally, like everybody else, once you're suffering from these sorts of things, you end up feeling that you're irrelevant to the community, you're not important, or you shouldn't be you're not regarded as to belong to the community. So this training, the human rights training, is a way of informing the users and their carers, the people that take care of the people with mental and neurological disorders, to understand that just like everybody else in the community, they too have the same, they're supposed to enjoy the same human rights like everybody else. They can access the same schools, their children can access the same schools, they themselves can use the same services like everybody else, the roads.
Right to what? Vote.
This group of 32 mental health patients in Kamuli district is part of the over 250 mental illness patients currently undergoing rehabilitation, medication, reintegration, psychosocial support and empowerment in human rights and advocacy under the support of World Vision Uganda. The training is aimed at informing them of their human rights, how, where, and from whom to advocate for them. It's a starting point for them to know which rights they are currently enjoying or being denied in their communities.
And that is what this training does for them, equipping them with the skills of how do they then approach the people who are responsible to be able to advocate for these rights. And what are the systems and processes that they can use to actually get these things done for them. And that is why we go into the steps of giving them the communication skills. How do they relate to the people who are in charge, the district health officer, the COW, the chief administrative officer.
Resulted from the results of the research that we did, which showed that there's a lot of substance use in Kamuli district, there's a lot of mental health related issues in Kamuli, domestic violence and other issues like epilepsy is very prevalent in Kamuli. But Kamuli in itself does not have a regional hospital, so we had to include Jinja, which they refer to, and so we have Jinja as one of the districts also we are piloting with. But also we have Kitgum.
Thanks to the Mental Health Gap Action Program, AMH Gap, being piloted by government in the districts of Jinja, Kamuli and Kitgum, World Vision is funding the 5 years implementation of the MH Gap piloting in Uganda as one of the pilot countries in Africa. The implementation is done by Ministry of Health in partnership with the World Health Organization.
This program is coming up as a World Health Organization program in partnership with the Ministry of Health. And here we are trying to scale up access to mental, neurological and substance use disorders in Uganda. And we are doing this by increasing the capacity of health workers. In each district, we have trained more than 200 health workers. And this we have done already in Kamuli, in Jinja, and also in Kitgum. We've also done the capacity building through sensitizing and training the VHTs, the village health teams. We have done this already in Kitgum. In every district of where we are piloting, we are training 400 VHTs. That's our target. And in Kamuli, it has been very successful. We have trained all the 400 actually turned up. And we've seen already increase because we train these VHTs to be able to identify people in their communities that are having mental, neurological and substance use disorders and be able to refer them to health facilities.
Service used to be centered here alone. But after the training, I realized that I can even connect with my fellow staffs in peripheral centers, that they can send whichever patients they do what they receive there in case they cannot manage them. And even the reporting of cases that we receive here has improved.
Specialized mental health units in Uganda are only at 13 regional referral hospitals, but they too lack adequate medical supplies for mental disorders. Because of this, all major and minor mental health cases have to be referred to the Butabika Referral Hospital.
Because of the wage bill not being big enough, so we proposed a restructuring to increase the numbers at all levels. And also we have been now started training of clinical psychologists, because some of these issues don't need medicine. They need what we call psychotherapy by psychologists. So also training psychiatric social workers. But the positions, they are there. We have trained some, but the positions are not yet there. So what we're advocating for now is the expansion of the structure so that we can provide in the establishment these positions, because we need them.
The program is premised on the ground that with proper care, psychosocial assistance and medication, tens of millions could be treated for depression, schizophrenia and epilepsy, prevented from suicide and begin to lead normal lives even where resources are scarce.
It has really helped us because these communities, we know we have been also going to the radio to at least sensitize the communities. And the communities are now aware, because I attended one whereby the callers were really wondering, because they were saying mental illness, maybe it's demon based, but we really assured the communities that it's not demon. Mental illness is really real, and it can be managed using drugs.
The Uganda MHGAP project aims to improve the well-being of girls, boys, women and men affected by mental, neurological and substance use disorders by improving the environment for delivery of quality mental health services at all levels of primary health care, improving capacity of human resources to provide mental health services, and by improving access and utilization of services for people with mental, neurological and substance use disorders within primary health care. Some of the patients we spoke to told us about the challenges they are facing while on medication, plus the positive changes they are seeing in their lives.
Bansibula 2006 nembedawo nga ndi bulungi ate 2007 nebuddamu ate ne banzaayo Butabika. So olwakomawo ever since, at least amakerenda ge basooka okumpa gaali gankosa mu by'obufumbo nenzirayo Butabika ne bankyusizaamu katimira kabamazapine. Era kabamazapine oyo mumira every morning situation bwe ndaba nga waliwo ekintu kyakalanyiza at least I put an added dose much as I'm not meant to do that, but in case of any disturbance I administer that drug. Kale, I'm responding positively towards that Kabamazepine.
Kyetusaba nga ife abalwaire abalina obuzibu obwo tusaba gavumenti etuyambe etufunire eddagala libengawo erimala mu madwaliro kubanga oyinza okuba eri abalwaire banange asobola okulwala yava ku mpeke yaira ku mpiso aye empiso ya bbeeyi kyokka osobola okujjayo ffe Mulago empiso bakati yezirawo empiso ya mitwalo esatu kyokka edoozi oyima nti gifuna buli mwezi abakati empiso ya mitwalo emeka esatu. Kale twandu baye tusaba gavumenti etuyambe etufune eddagala eryo waire lya mpiso libengawo full time wanga oluisi titwesobola bulungi nimwe mbandu wanonze eryo nga bwe nkola nti ejenta tisobola akola mikakaalukanu ngeri amakana gangi ganafuja tisobola akola migumu ino kiri awo. Kale twabaye tusaba gavumenti eno etufunire ate se eddagala libengawo mu bungi nga tiri waawo eryo ife ababulwaire buno.
So far, the program has managed to develop and disseminate a mental, neurological, and substance use policy guideline plus a mental health strategic plan. It has also trained medical workers, medical clinical officers, and nurses in medical health care using the MH Gap Intervention Guide, trained 600 village health teams to be able to recognize and refer mental health patients, plus sensitizing and orienting district leaders on how to lobby for support towards the same cause.
And if you look at Kitgum, it suited best because there's a lot of, if you look at the statistics recently, there's a lot of suicide happening in Kitgum. The suicide rates are highest actually in the country. We also have this post-war conflict, and which affected the LRA conflict in northern Uganda, affected a lot in Kitgum. Yet if you look at the interventions, less was done in Kitgum district. And so we and also together with the nodding syndrome that has been hitting Kitgum a lot and the country as well. So with all these factors, Kitgum seemed to be the most suitable district for implementing this, for piloting the implementation of this program.
With the MH Gap intervention, there is hope that mental health services will be integrated in the National Healthcare Plan and implemented at all levels of primary health care for the improved well-being of boys, girls, women and men affected by mental, neurological and substance use disorders.